So may I ask a question? How many of you are using pre-chopper in cataract surgery? Anybody? In soft cataracts, it is very difficult to hold the nuclear mass. We know that. So pre-chopper is a nice tool in such cases. We do in some way. We tilt the nucleus. We prolapse the nucleus out of the capsular bag, and we manage somehow. But in all those cases, we have to make a large rhexis. Suppose the patient is for premium IOL, and you have to do a small rhexis of about 5 millimeter. It's very difficult to prolapse the nucleus through that small rhexis. So in those cases, and in any case, if the nucleus is soft, it is really very good tool to manage the nucleus. So I'm going to show 4 cases. Rhexis has been done, and pre-chopper goes. This is real time. And in few seconds, you can divide the nucleus into 4 pieces. And now your job is just to go pick up each nuclear piece and just remove the pieces. Remove some superficial lens matter, hold the nuclear pieces. It is like you have cut a cake into 4 pieces and you are just picking up each piece and eating off. So this is the 3rd nuclear piece. Ultrasonic energy is very less, about 50 to 60%, or maybe even 30 to 40%. And vacuum is about 400, flow rate 40. And epinucleus is managed after that. That's not, we can skip this. Now another case. Pre-chopper goes. In the left hand is the sustainer. 4 pieces. And all these cases have been done day before yesterday, on 3rd January. This nucleus is about grade 3 or maybe grade 2 plus. So those who have not yet tried this instrument, a pre-chopper, I would insist that you just see this instrument. I have no financial interest, but it's a great tool in your surgical armamentarium. Now, in the 3rd case, I'll tell how to go about it. We have done rhexis, done hydro, injected visco, and now you are going with the pre-chopper. Just in front of the main wound, just avoid the, just in front of the anticapsular rim, place the pre-chopper. The sustainer goes then to the opposite equator. And now you hook the opposite equator and the 2 instruments come to each other. This cataract appears grade 3 nuclear sclerosis. So if the nuclear sclerosis is from grade 1 to grade 3, this is a very nice tool. Once the nuclear pieces are divided into pieces, it's just, you just have to pick up each nuclear piece and emulsify. First, and for picking up the pieces, we just place the phaco needle bevel down, and as we start emulsifying, the bevel is sideways. During emulsification of the last piece, we have to be very careful This is the last case. Rexis has been done, hydrodissection has been done, visco has been injected. Now the pre-chopper goes. In few seconds, in this case, the pre-chopper remained at the center. This pre-chopper has been designed by Dr. Sohail from Nanded, Maharashtra. And he has patented this instrument in his name. So, thank you very much. Any questions? Yes, it is available with Dr. Sohail. Huh? Akahoshi pre-chopper, I tried. Akahoshi pre-chopper is learning curve is little more, and the separation is less. But here your separation is as much as you want. So.
See, I have tried the Akahoshi pre-chopper, for the variations. It is okay for maybe 40-50 cases, but after that it becomes extremely hard. It doesn't really work out well. It is not cost effective. Yeah, but then I think this one will be best more desirable because it is cost efficient.
Thank you, Dr. Pradeep Manta. Now, next talk is by Dr. Arup Chakrabarti, and he'll be talking about
Yeah. Okay. So,
ACG.
start. Okay. So my talk is phaco pearls in angle closure glaucoma. We do cataract surgery in a lot of challenging situations, and one of those happen to be angle closure glaucoma. These patients are different from the routine, and certain precautions have to be taken for you to have a smooth journey during the surgery. So let me show you one case. This was a lady in her mid-60s, angle closure glaucoma. EAC PI was done. Patient was on prostaglandin analogs, and pressure was in the mid-teens. Anterior chamber was more than 2 millimeter in depth. So these are all the criteria which have to be satisfied before I take up these patients for cataract surgery without any preoperative, without additional preoperative workup like IV mannitol and all that. Now, if you see carefully, as I make the inferior paracentesis, the MVR blade, it sort of touches the anterior capsule. There's no puncture, but then it is just to show you that the anterior chamber is very shallow in this case. So superiorly, I had to be very, very careful. By this time, the anterior chamber has suddenly started becoming very shallow, and the eye has started becoming hard. Now, what do I do? So patient had absolutely no complaints, no pain, and patient did not, the red reflex that you see is still there, so I'm sure that it is not a case of suprachoroidal hemorrhage that I'm dealing with, or maybe just mild suprachoroidal effusion. So I started an IV mannitol fast drip in this particular patient, a bolus. It is not an ideal situation, but then I thought something is better than nothing. And in the past, where I have had intraoperative hard eyes, when I've given IV mannitol, in about 10-15 minutes time, the eye generally settle down. In this case, nothing of that sort is happening. So this is actually not an edited video, so it takes a little longer time. It is real time. So I injected a lot of OVD into the eye. Intraocular pressure goes up farther. Now, if you have a compromised optic nerve head in this kind of situation and with a high intraocular pressure, you can definitely have problems with the blood supply to the optic nerve head, and if it is a damaged optic nerve head, then your patient is in for trouble. So the rexis starts off. I have to be careful that the rexis doesn't run to the periphery. Fortunately for me, it is not a very hard cataract, because if it is a hard cataract, the minimum size of rexis is about 5 to 5.5 millimeter. So in this kind of nuclear sclerosis, I can still escape with a smallish rexis. What happens in this particular case, about 4.5 millimeters in size. And the rexis goes on, and still the eye doesn't show any evidence of becoming soft. So then I decided that I should do a past planar vitrectomy, and so this is again I mean before when the sisters are setting up my vitrectomy unit, and then I use my trocar cannula system, 23 gauge trocar cannula system through the past planar. So this I can see that you can visualize the tip of the cutter, and so it was not a blind procedure for me, and I have been trained with this with the past planar approach by a VI surgeon who happens to be my wife, and I've been doing it for the last more than 15 years. So here you can see the cutter tip, it is cutting, and I can make out the eyes becoming soft. So when I feel the eyes soft enough for me to go ahead with routine phacoemulsification, I start off phacoemulsification. Subsequently, the phaco goes on pretty smoothly. There's nothing much to write home about here. See, this is a cortical cleaving hydrodissection that is being performed. So normally, you need to evacuate the OVD that is accumulated within the anterior chamber before performing cortical cleaving hydrodissection. So that was done in this case, and subsequently all the steps are routine. I started off with nucleus removal is pretty simple, and a hydrophilic acrylic intraocular lens was implanted within the capsular bag. When I closed the case, the eye was soft, and it was like a routine eye. The intraocular lens was very well centered, as you will see here, and yeah, so the surgery went up pretty well, and post-operatively the patient had done extremely well. So what I just want to tell you is you need to be ready to modify your surgical strategy depending upon your experience. So today, whenever I have a patient with angle closure glaucoma, regardless of the intraocular pressure, regardless of the anterior chamber depth, I give an IV mannitol 200 cc 1 hour before patient comes for surgery, and then the patient is taken up for surgery, and the eyes really become very soft in these cases. So for the take-home message from this particular case presentation or surgical video presentation, is you must detect the conditions which may predispose to intraoperative hard eye, not only angle closure glaucoma, but patients with severe exfoliation, zonulopathy, etc., etc. Cortical cleaving hydrodissection has to be done extremely carefully, bypass the additional OVD from inside the eye. Be alert to pupillary snap sign. Cortical cleaving hydrodissection is one step of surgery where I don't blink, because moment if I miss it and if I go ahead with unmodified phaco technique, I'm sure to encounter a dropped nucleus situation. So quickly consider the differential diagnosis of intraoperative hard eye. If you suspect the suprachoroidal hemorrhage, it is mandatory for you to stop the surgery, not to proceed. I would not have proceeded if it was a case of suprachoroidal hemorrhage, and refer the patient to a posterior segment surgeon, and maybe after 2 weeks or so taken up the patient for surgery once again. In other situations, IV mannitol may help. Ideally, it has to be given much before surgery. Some situations where I had an intraoperative hard eye before IOL implantation, I have just temporized. I have taken out the patient at the end of the day or at the beginning of a fresh OT day. Eye was pretty soft and there was no problem at all. So it is useful to wait for these cases instead of trying techniques like past planar vitrectomy if you're not aware of how to do it, if you're not trained in doing past planar vitrectomy. And there's some surgeons who have also done 26 gauge past planar vitreous aspiration. It is reported in the scientific literature with supposedly good results, but I am not a big advocate, not a big fan of this approach. So if you have spoken to the patient preoperatively that there is a possibility that the surgery or IOL implantation may have to be done at the second stage, it definitely saves the day for you when you encounter this complication. Thank you so much for your attention.
Thank you, Arup, for excellent presentation. Now I invite Dr. Vijay Sharma. And I just have to I think it is very good if you can do past planar vitrectomy, and many of the anterior segment surgeons are not so well trained. So what I have been doing recently, all the patients who have got a shallow chamber of say 2 millimeter around in those cases, I do not do any hydro. After doing Rexis, I straight away start doing phacoemulsification. So that way, because I do stop and chop, remove the epinucleus, crack the nucleus, so the eye, you have already debulked quite a lot of the nucleus over there. And most of the time, it is possible to rotate the nucleus without doing hydro, because the fluid keeps on going inside the eye. And if it rotates without doing hydro, or like in a posterior polar cataract, we lift one heminucleus and then lift another heminucleus without any rotation. So I'll go ahead and proceed with the removing the nucleus or rotate it. If it is not possible, then of course I'll put on a viscoelastic little bit and do the hydro after doing all other steps of debulking. So that way
It is an auto hydro, like when you do phacoemulsification, the fluid finds its way out.
So if you are able to do it, rotate it and bring out the nucleus either by rotation or without rotation is fine. If by any chance you feel that the jonules are weak, you are not able to do it, you can do the hydro after debulking the part of the nucleus and the epinucleus. So that way I have been able to manage the shallow anterior chamber actually very well in those cases.
This was the pressure was also very high.
No, your technique is ideal. I am not debating that.
No,
That's
this is
perfectly
for the
all right.
audience. This is for the
So,
audience.
but many of the many of the anterior segment surgeons don't feel very comfortable going through the pars plana, doing a vitrectomy and doing one more step. So if the IOP is not so, intraoperative hard eye is entirely different ball game. But just in case of a shallow anterior chamber, which is say 1.5 millimeter to 2.5 millimeter, the chamber is very shallow. In those cases, you can do the debulking of the nucleus, and there is no need to do the hydro, which really puts a little more fluid and increases the pressure.
So another thing you want to tell is that use of trocar cannula system is not mandatory. If you are trained, fine. Otherwise, you can just do a direct vitrectomy, single port, and end up closing the incision with a tenon-nylon suture or a vicryl suture if you have that in your inventory.
No, I'm not debating that.
No, I'm not telling you. I'm just telling the audience.
Most of us, even an experienced surgeon like us, are reluctant. So I'm sure many young people will be very, very reluctant to go through the pars plana, and they maybe have a little doubt of damaging the posterior capsule, whether the vitrectomy cutter is in a working condition or not. So there are a lot more things involved when you put on another total new set of the instruments and equipment.
Yeah, I agree, sir.
We'll now invite Dr. Vijay Sharma. He'll be talking about corneal laceration. Management of traumatic cataract corneal laceration.
Very good evening to all of you. I will be discussing a management of traumatic cataract with concomitant corneal laceration. As we know, direct injury to the crystalline lens by the foreign object or by blunt trauma to the globe leads to the formation of traumatic cataract. Penetrating or perforating injury leads to laceration of the cornea sclera along with the injury to the internal structure of the eye. Severity depends upon the zone, type and grade of the injury. So corneal laceration with traumatic cataract usually associated with the associated ocular injury depends upon zone, grade and type. It can be associated with the rupture anterior or posterior capsule, subluxated crystalline lens, retained intraocular foreign body, endophthalmitis, hyphema, vitreous hemorrhage and retinal detachment. However, the challenges associated with this kind of cases is like timing of cataract surgery after the trauma, and IOL power calculation with if associated with the corneal laceration, and approach of surgery whether it is limbal or pars plana, primary implantation versus secondary implantation, and timing of corneal suture removal. I mean, it is more difficult when there is no capsular support. So challenges associated with the pediatric age group is different, like development of amblyopia, intraocular inflammation, a strong vitreal retinal adhesion, early development of posterior capsular opacification, and needs of general anesthesia. So there is no consensus guideline whether about the timing of cataract surgery. However, initial laceration of the lacerated wound or later when the eye has recovered from the injury, patient with penetrating injury with corneal laceration, acute traumatic cataract without capsular rupture, secondary procedure is to be followed. So corneal laceration with anterior capsular rupture, primary corneal laceration, followed by the cataract extraction with primary IOL implantation within 2 weeks of injury is to be followed. So these are the challenges like IOL power calculation, poor capsular support or subluxated lens, raised intraocular pressure, approach of the surgery whether limbal or pars plana. So I will discussing a case 1 where the corneal laceration with the rupture anterior capsule is there, a 24-year male. There was zone 1, grade type B and grade 4 injury was there, and the post-op day after the primary repair. On post-op day 1, we can see the anterior chamber was shallow with the anterior capsular rupture and the cortical matter in the anterior chamber touching the cornea, and intraocular pressure was 30 mmHg. However, posterior segment was normal on ultrasound. So post-op day surgery And the post-op day 1 week, we can see the IOL was well center, corneal suture are there. So even after the proper optimal management, we can see the patient develop the corneal scar. So whether we can try contact lens or we can go for the penetrating keratoplasty. So case 3 where the challenges of IOL power calculation, similar patient, there was a similar patient with corneal laceration with rupture anterior capsule. So IOL power was taken from the other eye and the 25 diopter IOL power was selected. So in this case, we can see the tryptophan blue is used to stent the anterior capsule, and the in view of suspected posterior capsule tear, I just pushed the triamcinolone to see the any vitreous in the anterior chamber. So carefully cortical cleavage is done, and the IOL is implanted in the sulcus, as there is a no anterior capsule. However, the posterior capsule was intact, and the primary posterior capsulotomy was done, and IOL remains in the anterior in the sulcus. There was no posterior capture was performed. So in this case, we land up with the surprise of myopia of -3 diopter sphere. So ideally, one should do the primary posterior capture PPC along with posterior capture, so that we cannot land up in the myopic surprise. Similar another patient where the posterior optic capture are performed. In this case, similarly anterior capsule was ruptured. We can see there was a posterior capsular hole. So gently cortical cleavage was done. The viscoelastic is injected, and the IOL is placed in the bag. And now the the posterior capsulotomy is enlarged, and the visco has to be aspirated from the back up, and the posterior capture should be performed like this. So another patient which is present with the corneal laceration along with the rupture anterior capsule, so and with the astigmatisms. So I went ahead with the toric IOL in this case. So little bit of eccentric capsule reduction is made, and it is away from the rupture anterior capsule. So carefully cortical removal was done. So we can see the there is a anterior capsular rupture. Now the toric IOL, which is around 86 degree of axis, it was implanted. So little bit of eccentric capsular access was done in this case. We can see 360 degree coverage of the optic was there. So if they do the like delay cataract surgery, which leads to the formation of the posterior synecdoche and the more inflammation, and the adhesion is there. So we can see in the delayed cataract surgery, there was a synecdoche formation. So it is difficult to release the posterior capsule from the iris from the posterior capsule. So I'll just place in the sulcus after creating the sulcus. So injury with the lens capsule violation did better when the lens material was removed meticulously during the primary repair. Post-op inflammation, synecdoche and fibrinous uveitis decreased drastically in the primary lensectomy group. Several studies suggest that the delayed lensectomy increased the morbidity. Thank you.
Thank you, Dr. Vijay. It was a nice talk. So just one question that I could able to see you implanted a patient with the corneal suture intact. So normally even people prefer to remove the sutures and wait for because I could able to see there is a residual refractory error remaining around 3 sphere with the
Minus-
supplement
yes, sir.
of astigmatism.
Yes, sir.
Why you really thought about that? Remove the suture, let the eye cornea get stabilized, then later on put a second ray IOL.
Yes, sir. Sir, and usually if the anterior capsule is ruptured, so it's better to do the surgery early because it will lead to the more inflammation and the more formation of synechial formation and the increased risk of glaucoma is
Now
there.
remove the cataract, make the patient aphakic, then remove the suture and second sitting you can still
Yes, sir.
put the
And
intraocular lens.
basically this the open globe injury and this in the children age group, so risk of amblyopia is there. So one should rehabilitate the patient if they put the IOL is there.
Okay, thank you. Parikshit, any suggestions? So thank you so much.
Okay.
Let us come to the next speaker. I think next talk is by Dr. Sanjay Chaudhary. Dr. Satyajit Sinha is around. Dr. Sanjay Chaudhary, he will be talking PCR to PCCC. Dr. Anurag Mishra is here. Then I think you are the last speaker.
Okay, thank you. So, we talk about PC rents, and it is fairly important that you should be in a position to convert small PC tears to posterior CCC. That really saves the day. One, it prevents your rent from running out. Two, you are still able to salvage your surgery and probably put a lens in the bag. And if you are doing a toric IOL, then it is really a lifesaver. You can still put a bag on the right axis in the bag, the IOL. So here's the case, a typical posterior polar cataract. Everything went fine till this last point when we had a rent. The first thing when we get a rent is we stop, we put an interior chamber maintainer. It's standard. Any rent, first put an interior chamber maintainer attached to a bottle height of 42 that keeps the IOP at 30, low IOP. Then try to remove as much of the vitreous as you can from that area, preferably just behind the lips of the rexus margin. Also, once the vitreous is away, you can use the same vitrector in the IA cut mode and hold the cortex and bring it in the center. In these situations, many a time the cortex still has a vitreous strand attached to it. So as you cut the cortex, you also cut the vitreous strand. So you don't use an IA system, use a vitrectomy IA system. So you exposed one end of this rent, use a 25 gauge micro-rhexis forceps. See, there's a strand attached to it. You can make out. There was a vitreous strand attached to it. So, try to cut all the vitreous from under the lips of the torn margin. I've exposed one, did a rhexis. Now I'm going to expose the second end of the torn margin. Now all the cortex is clear, and this is the position that you see. Now what you see here is one more torn margin here. You know what is this? What is this? Yeah, typical tenting. That means there is still a vitreous tag coming out from here into this incision. So this is what I have to handle. So I get this vitreous tag out. Either I cut it, or as I separate it, it sinks into the vitreous cavity. That is why your IOP should be very low. High IOP is going to churn up more vitreous and bring it up. So 30, 25, whatever. And the same technique with a micro-rhexis forceps, you hold the edge and turn it around. And in such a situation, you can put a IOL in the bag. So this is what I said, if you have a toric or something, you are still bang on, you are still going on where you want to. So the rule is that whichever edge you are going to tear and make a rhexis rounded edge, there should be no vitreous there under the edges of the flap of the torn capsule. The flap has to be absolutely loose without a pressure from the vitreous. Only then can you hold it. And the second rule is normal magnification that you work at, you need to make some changes. One is you increase the magnification. Two, you increase the illumination. And three, it has to be totally retro illumination. Oblique illumination is a big distraction, and it spoils your quality of visibility and therefore the way you handle the torn edge. So a similar situation. Why I showed you exactly a similar situation, that this technique is replicable. Again, using the cutter in the IA cut mode, exposing the torn edges of the rhexis. Now I have done the magnification. I am in totally retro illumination, and now I can see one edge here. Sorry. So I can see one edge here, comfortably hold it and turn it around. See, it's technically very simple, as if you are tearing a anterior capsule. Hold the other edge, turn it around, both your edges are rounded, you are safe. Now this is the size of the opening. Now you have to choose with your experience whether you will put a lens in the bag or in the sulcus. You can do both, depends upon your level of confidence. So even in this I could put an IOL in the bag, but at that time I decided to place it in the sulcus. So I use a 3-piece lens, putting it in the sulcus. And see, I am putting the IOL under hydro, no visco. Once there is a PC rent, visco is out. I don't want that visco falling in the vitreous cavity. That will cause problems at UG syndrome later. Everything is under the ACM. Both my hands are free. I am doing this optic capture. Everything is under hydro, under ACM. See, no irrigation separately. Both hands are free at all times to do all the maneuvers. And a complicated situation like this looks so simple, as if it is just happening as a routine. Now, it is said that anterior segment surgeons would naturally do an anterior vitrectomy. And time and again it has been said that you cannot do a good vitrectomy and go behind the posterior capsule through the anterior route. And again, it is stressed that yes, it is time that anterior segment surgeons should have some basic idea of pars plana vitrectomy, just core vitrectomy, and you just go under the capsule and eat it up so that you free the capsule, posterior capsule, and then you can do whatever with it. So I'll show you an example. A PC rent, forget the nucleus part that came out, so much of vitreous. First step, if there is vitreous, put an anterior chamber maintainer in place. Now my both hands are free, one hand the cutter, one hand the manipulator, so I can keep pulling the tags of the vitreous and keep cutting them. But then I followed the example of pars plana vitrectomy. It's very simple. You put in a trocar and put in a cutter. That's it. The distance has to be 3.5 millimeter from the limbus, and see the way comfortably you can remove all that vitreous from behind the posterior capsule. The posterior capsule is so clean and separate from the vitreous. Now you do whatever. And the biggest advantage is the principle. The fluid is coming from the AC, from the anterior chamber, and it is going backwards toward the posterior chamber in the vitreous cavity. So from front, the movement is behind. So the vitreous is not coming up. Everything is getting sucked behind. So it is not that the feeding area is also through the pars plana and the cutting through the pars plana. The feeding is anterior chamber. The suction is out from the posterior area. So that flow keeps the vitreous away, and it helps you free up the vitreous very comfortably from behind the torn edge. So some take home points. The moment you have a PC rent, the first rule in our system is we have a special box, which is a PCR box. It has an anterior chamber maintainer, it has a microrhexis forceps, it has a tricot, it has all these things attached to it. So the rent, he opens up the box. First thing is you put in an ACM. Let the pressure build up to 30, relax, now watch what is wrong. And then treat it step by step. Now there is no hurry at all, because the chamber is going to be stable all throughout the surgery. Pressure has to be low. Higher pressure, you are going to hydrate the vitreous. That is going to be a tough challenge. So keep your pressure as low as possible, as close to the physiological pressure of the eye, because even a PC rent, in the physiological pressure of the eye, in a normal closed eye, the vitreous does not get churned up. It stays where it is, right? We have all experienced that. So it is not that the aqueous is going to the vitreous all the time in a closed eye. Just keep the pressure low. Second, anterior vitrectomy is a must. No vitreous should be under the rim of the torn capsule. Grabbing the torn edge is difficult if vitreous is attached to the torn edge. Pars plana is a better option, definitely. You just have to get over that little hitch, and it is a far more superior way of handling vitreous loss. You have to improve your visibility by these three cardinal ways: increase magnification, increase illumination, total retinal illumination. And you see that posterior capsule line so clearly. You see that torn edge so clearly. And you need to have a 25 gauge microrhexis forceps, not a 23 gauge. Because your side port, which is 1 millimeter, 23 fits into it, but it doesn't give you that flexibility of moving around. 25 gauge, it also gives you that flexibility of going right, left and holding the edge and bringing it around. So 25 gauge, hardly, very few people are making it, but it has to be a 25 gauge. No visco once PCR is detected. Absolutely no visco to be used throughout the surgery, as it falls in the vitreous cavity, causes problems. Thank you so much.
Excellent, excellent talk, Dr. Sanjay Chaudhary, but was quite interesting. When we learned initial part of our career that whenever there is a rent recognized while doing phaco. So do not withdraw the phaco in phaco probe. Go to the foot pedal position 1. From the paracentesis, you inject a viscoelastic and you take out a phaco probe. That's what
We have
people
always been learning. Yeah.
That's what we have been learning with the same. Go to foot pedal position 1. From the paracentesis, you inject a dispersive viscoelastic, then
And
you
then you
remove
come
the
out.
frig.
Yeah.
But it is quite
This
interesting.
changes the whole concept.
Yeah.
But
But
it is
what I
working.
just wanted to ask you, whenever there is a rent, that means you will not withdraw the phaco probe from the eye, no? Then you will, from the side port, you will connect this flow of 30 centimeter height fluid.
Yeah. Side port, or you'll make another port for it.
And as you said that, I think nowadays most of the people, I think most of the institute, postgraduate institute, actually they are training the fellows to be much familiar with the pars plana vitrectomy, because the amount of pressure what it really exerts compared to the on the anterior approach is always better. But it was excellent videos. You did a very nice capsular axis.
Thank you. Pars plana is always a fear. So if you work in an institution where retina is also happening, it is easier for you to pick it up. That's it.
Thank you, sir. Let's go to the superstar of Patna, the man who is really making this conference really happening one, none other than Dr. Satyajit Sinha. Doesn't require any introduction. He is also member ARC, All India Ophthalmological Society. So he will be talking about his experience in management of cataract with post-recurrent uveitis. Over to you, Satyajit.
I'll be speaking on management of cataracts post-recurrent uveitis. One of the things we have to keep in mind is that the patients are so boggled and they are so traumatized with the uveitis that they are dealing with, that they think that after they have the cataract surgery, they will be seeing absolutely fine, and we are not able to reach their expectations. Now, cataract is a common complication of uveitis, we know, and it depends on the duration of the uveitis, chronicity, location of the inflammation, and use of corticosteroids. The factors influencing the outcome are types of uveitis, the control of the inflammation, the appropriate surgical technique, intraocular design, and the management of post-operative complications, which is one of the most important things. Now, good to excellent outcome is anticipated in Fuchs heterochromic iridocyclitis, burnt out or inactive idiopathic anterior uveitis, in HLA-B27 associated uveitis, and in inactive toxoplasmosis. Moderate to good outcome is anticipated in pars planitis, Behçet's, intermediate uveitis, sympathetic ophthalmia, birdshot retinochoroidopathy, VKH, sarcoidosis, and inactive infections. Now, one of the things that we have to be careful about is juvenile rheumatoid arthritis. When you are undertaking cataract surgeries in this, you have to really decide what procedure you want to undertake, because these are the patients who have severe inflammation even after the cataract surgery. Preoperatively, we have to do a very good comprehensive ocular examination, a systemic examination, and relevant systemic examination has to be taken care of. Things like fluorescein angiography help us in detection of active posterior segment disease and CME. OCT also helps. B-scan and ultrasound biomicroscopy also help us in making the diagnosis. Now, Foster et al. Have described 4 indications for cataract surgery, and you have to make a very calculated decision when you're taking these patients up for surgery. One is phacoantigenic uveitis, the active inflammation as a result of leakage of lens proteins, in which case cataract surgery is mandatory. Visually significant cataract with well-controlled inflammation and potential for visual improvement exists. And cataract impairing visualization of the posterior segment, especially in cases of suspected retinal or disc neovascular and other retinochoroidal pathology. Cataract impairing visualization of posterior segment in a patient undergoing VR surgery. Now, comorbidity also adversely affects the visual outcome. Concurrent glaucoma or hypotony, band-shaped keratopathy, extensive posterior synechia, RD, optic atrophy, CME, macular atrophy, or whole epiretinal membranes and vitreous opacity. Some of the things which over a period of time when you have uveitis, these comorbidities also give a poor prognosis. Now, this is one thing which we have to really remember, is that elimination of inflammation for at least 3 months, preferably before the surgery, is desirable after the inflammation becomes quiet, before you take up the surgery for cataract. The rule of thumb is to operate only when cells are absent 0 to 5 in the anterior chamber as assessed on the slit lamp. In cases of vitritis, reduction of vitreous cells is desirable, but these persist even in inactive stage and cannot be completely eliminated. Now, before the surgery, oral prednisolone 1 mg per kg body weight along with topical prednisolone acetate 1% eye drops 8 times a day starting 2 days before the day of the surgery, along with oral topical non-steroidal anti-inflammatory agents. In severe cases not responsive to steroids alone, or in those where steroids are contraindicated, immunosuppressive agents such as azathioprine 1 to 2 mg per kg can be started at least 4 weeks earlier. Now, we know that phacoemulsification is one of the safest techniques. We have to take care of the management of the small pupil, especially in these kind of cataracts. You will encounter posterior synechia and small pupil. In juvenile rheumatoid arthritis, one of the things that you can think about is, even today, is intracapsular cataract extraction, but you have to plan it. In some cases, you may also need to be doing pars plana vitrectomy. And pars plana vitrectomy has its own complications which are associated with combined procedures, including increased incidence of CME, increased post-operative inflammation, choroidal hemorrhage, vitreous hemorrhage, retinal detachment, or late IOL decentration. IOL implantation in cases of uveitis has now become routine, but you may also want to keep in mind that there may be posterior synechia, the formation of pupillary membrane will be there, cyclitic membranes, IOL decentration may be there, capture or subluxation, secondary glaucoma may be there, hypotony or CME. The types of inflammation, the suppressive and the expertise in using immunomodulators has become such that we probably can master most of the resistant inflammatory situations. In such cases, the question is no more whether the inflammation pattern allows implantation, but more whether the appropriate follow-up can be done or not, which is the most important thing in these uveitis cases, whether the patient is coming to you for follow-up. Acrylic IOLs provide better visual outcomes with lower rate of complications. The challenges, as I said earlier, is small pupil. We have already discussed that. Severe immediate post-operative complications include severe post-operative inflammation, secondary glaucoma, and flare-up of the primary disease. Late post-operative includes CME, secondary glaucoma, uveitis, persistent inflammation, posterior capsule opacification, and hypotony. In late post-operative, there may be cyclitic membranes, intraocular membranes, posterior synechia and IOL capture, reactivation and toxoplasmosis, epiretinal membrane, retinal detachment, and phthisis bulbi. Now we have a patient over here who was 38-year-old female who came with history of treatment of CS cervix. Her old reports revealed COX. She came to us with counting finger in both eyes, and we diagnosed her with dense PSC in both eyes. She had a festine pupil and she had a uveitic macular edema in right eye. She was given Tricot injection. This was the OCT picture. She was given Tricot injection intravitreal in the right eye, and then phacoemulsification was planned after 15 days. Systemic steroids were also started preoperatively. And this is the video that I would like to share with you. This is the preoperative picture. And in these cases where the pupil is small, when you are releasing the posterior synechia also, there is a chance of hyphema, which you have to take care of. And most of these cases, it's very difficult to use Malugin rings or B-hex rings. So, and when these pupils are small, even if you use phenocane, they will not expand. So you have to use iris hooks. And these cataracts are very soft. So you have to be very careful about that. And in these cataracts, the zonules may also be weak in patients who have recurrent uveitis. Sometimes the cornea is also not very clear, so the visualization also in these cases become difficult. The red glow may not be as good. So you make a rexis carefully, you make sure that you have done a good hydrodissection and rotated the nucleus. In these cases, you may also have a floppy iris, and you may be seeing in this video that there is a recurrent iris prolapse from the wound. So it is a good idea to hydrate the cornea to prevent that. You have to carefully remove all the nucleus which is there, and even when you are removing the cortex, you have to be careful so that the zonules which may be weak at some point, you don't put stress on that. One, you have to, and these cases also have the posterior capsule may also be very thick. So once you have done that, and you will see repeatedly I am using hydrating the cornea, and that helps me in keeping the iris properly at the place. You load the IUL properly and then implant it in the bag. And it's very important that after you have finished the case, you wash the viscoelastic in these cases properly, even from behind the IUL, as any remnant viscoelastic can make the post-operative inflammation even more worse. So you remove the thing, and this is the first day post-operative picture. This is after 1 week. This is after 15 days, and the next picture, this is after 1 month. The patient who came with us with counting figure now has 618 vision in her eye. This is the post-operative picture of the macula also. So the patient came with us to counting finger and has 618. The predictability has improved primarily because of a higher level of understanding of the uveitic disease among clinicians. Pre-operative factors include proper patient selection and counseling, where counseling is the most important thing, and pre-operative control of the inflammation. The use of immunosuppressive agents other than steroids also help in control of inflammation and has enabled long-term use of these agents, especially as steroid-sparing medication. Thank you so much for your patient hearing.
Excellent talk, Sajay. Couple of questions. One is, see, what is your preferred IOL? Do you really put a heparin-coated lenses in these cases?
Earlier it used to be there, but not so much now. Now the acrylic lenses which are there, hydrophobic lenses, are also as acceptable in these lenses.
Do you start 1 week or 15 days before oral Visalon or steroids for this patient?
At least 3 days before we start oral prednisolone systemic steroids, and we have to make sure that at least 2 to 3 months the eye is quiet, and then only we take up the patient for the surgery. But at least 3 days before we start the systemic steroids.
See, suppose patient with a post-uveitic mutton fat cape is around, and you did a B scan, and when you do operating for this one, you had already started steroid. Do you prefer, along with putting intraocular lens, by giving any intravitreal Ozurdex?
Yes, that is a very good suggestion, and in some patients you do need to put Ozurdex also to control the post-operative inflammation. Yeah. Yes.
Thank you so much.
Thank you so much.
Thank you for the opportunity. This concludes the day. Intracameral Kenacort also can be
Intracameral Kenacort, Ozurdex, intravitreal Ozurdex, they all will play the same role of preventing the post-operative inflammation.
Dosage of intracameral
I will not be able to answer that right away, but definitely it will help. Should be 0.1 milligram, something you have to dilute it. And thank you very much.